All right, thank you. Good evening, and thank you for joining us for another CME event sponsored by Wolfson Children's Hospital of Jacksonville. It is our pleasure to bring you this evening's presentation and hope you find it informative. I am Dr. Michael Gale, Medical Director of Outreach and Transport for Wolfson Children's Hospital. Sorry, my slides here. Oops. Oh, I'm sorry. It is my pleasure to be with you this evening. I'll be moderating this evening's presentation and will be joined by Wolfson Children's Hospital Business Development Specialist Faith Galloway and Sonny Capadi. The mission of Wolfson Children's Hospital is to promote optimal health for all infants and children we serve. Wolfson achieved this mission by providing patient and family-centered care, education, research, and by advocating for all children. Wolfson Children's Hospital is located in Jacksonville, Florida, at the intersection of I-95 and I-10, close to downtown Jacksonville. To better serve the patients and families in the referral regions of Florida and Georgia that comes to Wolfson Children's Hospital, we have developed a network of satellite clinics in our referral regions as shown on this map. Our presenter this evening, Dr. Stett, actually goes to Tallahassee, where he holds urology clinics. Before our speaker begins, I would like to cover a few housekeeping items. To ensure the best sound quality throughout the program, all attendee microphones have been automatically muted to reduce background noise. We have reserved the last part of the program for question and answers. Please feel free to submit questions during or after the presentation. To submit a question, simply use the Q&A feature at the bottom of your screen. At the end of the presentation, Faith will share a UPC code with you that will enable you to obtain your CME credit for attending this evening's presentation. This evening's presentation is by Dr. Andrew Stett. Dr. Stett is the Chief Division of Urology in the Department of Surgery at the Nemours Children's Specialty Clinic in Jacksonville. He's also Division Chief of Pediatric Urology at Wolfson Children's Hospital. And in addition, he has an academic appointment as a courtesy Clinical Associate Professor of Urology at the University of Florida College of Medicine in Jacksonville. Dr. Stett attended medical school at Emory University School of Medicine. He did a general surgery internship and urology residency at the Vanderbilt University School of Medicine in Nashville, Tennessee, which was followed by a fellowship in pediatric urology at the Johns Hopkins Hospital. At the completion of his pediatric urology fellowship training, Dr. Stett took a position as an assistant professor of urology and pediatrics at the Medical School of South Carolina in Charleston, South Carolina. And after a few years, he was promoted to associate professor level. Dr. Stett remained at MUSC for 8 years before joining the Nemours Specialty Clinic here in Jacksonville in 2019. Dr. Stett has participated in several research studies in pediatric urology, written several scientific urological publications, and given numerous presentations on pediatric urology topics. He's recognized both nationally and internationally in the field of pediatric urology. This evening, Dr. Stett's presentation will be on a topic that every PCP should know: hydronephrosis, reflux, and UTIs. It is my pleasure to introduce you to Dr. Stett.
Thank you very much for the kind introduction. I appreciate it. It's a pleasure to be here tonight talking to so many of the folks that I've talked to on the phone to date, but also people I'm still getting to know. I've been in the Jacksonville area with Wolfson and Nemours now for about the last 2 years. And those that I don't know, I hope to get to know better as time goes by. I'm going to get my screen shared with you guys and we'll get started tonight. Give me 1 second. I'm doing it. Share screen. All right, here it comes. So the point of this particular topic of hydronephrosis and reflux and UTIs is this tends to be what we get the most phone calls about. And there's a lot of very practical information that I don't think gets communicated down in a lot of thoughtful ways. And so we're just going to dive right into it, and hopefully I can dispel some myths and provide some fairly practical information for the pediatricians and primary care providers on the call tonight. I don't have any disclosures that are relevant to this particular conversation or this talk tonight. So we're going to talk about three things, and they're all interrelated. We're going to talk about prenatal hydronephrosis, why it happens, what it is, and what your workup should at the minimum be. We're going to talk about vesicoureteral reflux, when we should actually be looking for it, and some of the recent data to help you guide your patient care, and also the association with urinary tract infections that account for a huge proportion of visits to our primary care providers' offices. So we're going to start with prenatal hydronephrosis, and basically prenatal hydronephrosis, the incidence or likelihood that it will occur in the average newborn birth is about 1 out of 100. So somewhere between 1 to 3 kids out of 100, depending on what studies you use and what cutoffs you use, we'll get told that your child has caliectasis, pylectasis, hydronephrosis, a swollen kidney, a dilated kidney. So this has become a very common diagnosis for parents in the newborn or in the pre-newborn period. The likelihood that it ends up being some sort of significant urinary tract disease, though, is disproportionate, on the order of 10-fold less in magnitude. So the vast majority of these patients are not necessarily going to have significant urinary tract disease. So both the art and the medicine of prenatal hydronephrosis have to do more with identifying those patients that do need additional care or higher level imaging. And so whenever I'm talking to a family, if I'm prenatally counseling, or if I'm talking to a pediatrician or a primary care or family medicine physician, there's really only 3 reasons, and with a 4th rare category as to why patients have prenatal hydronephrosis. Number 1, this can be someone's version of normal, right? Hydronephrosis is a description of what we see on an image, and hydronephrosis means fluid in the kidney, and that is, quote, by radiological standards, abnormal. So in the world of hydronephrosis, it's not necessarily representative of a disease process happening inside the child in all cases. Sometimes people's kidneys and their plumbing systems just look different than we expect them to in the normal range. So having a normal variant being transient, disappearing, that's a very common phenomenon. Having obstructions or blockages in the urinary tract at a variety of different levels is the second most common phenomenon. Vesicoureteral reflux happens in about 1/3 of these cases. We'll talk a lot about that. And then there are some other rare cases, right? Parents get told your child has caliectasis or hydronephrosis or any of these bucket terms. And these are kids that have things like urethral valves or cystic renal diseases. We see all of that end up in our clinic somehow under the banner of dilated kidneys. I just put this picture up because in the world of the urologist, and when you're hearing about ultrasounds, this is a kidney, this is the renal pelvis. Oh, well, that's not nice. Let's go back. Don't act up. This is the renal pelvis, right? Where the ureter, this tube, and the renal pelvis join, this is the UPJ. P is in Paul. Where the ureter and the bladder join, this is the UVJ. V is in Victor, right? Vesicae is Latin for bladder, right? So UPJ obstruction happens up at the level of the kidney. UVJ obstructions, mega ureters. When you hear say hydroureteronephrosis, that's happening as it gets closer down to the level of the bladder. So when you look at this category of hydronephrosis and you think, if I'm counseling a family or you're counseling one of your patients, what could this be? Basically, the severity of the hydronephrosis prenatally determines what the likelihood that this is something postnatally. Reflux is always going to be, depending on the study you read, between 20 to 30%. I just say 25% or 1/3. It's easy to remember. As the hydronephrosis gets more severe, right? The patient that has 7 millimeters of dilation in the 3rd trimester versus the patient that has 40 milliliters of dilation, the difference between those 2 patients is as the degree of swelling goes up, the rate of obstruction goes up. So the patients that are born that are seen that have mild fluid in the kidneys, the likelihood of obstruction is low. In that whole population, it's 10% or less. A significant obstruction requiring surgery is even less than that. As you get to the more severe versions of hydronephrosis, we're going to find a lot more obstructive issues happening. And so basically in the milder versions, there's a lot more chance that those are kids whose kidneys are ultimately just normal without a disease process happening that would impact their kidney health or their growth in life overall. So in the world of hydronephrosis, you're going to hear a lot of complicated grading systems, but I keep it really simple. There's mild, there's moderate, there's severe. There's three basic buckets. The mild kids are the kids that don't really need to be worried about that much. Those are kids that if they never had imaging again, would most likely show up with some sort of symptom that would prompt an investigation, right? As we move up in severity though, that's where you start to see greater increases in patients having pathological processes that need to be managed, right? So mild hydronephrosis, caliectasis, pyelectasis, those are grades 1 and 2. Those are minor, right? Those are sort of low on the triage scale of how severe is this. Moderates become more medium risk. And the more severe they are, when they start to talk about changes in the parenchyma or the meat of the kidney or the echogenicity of the kidney, functional structural changes to that unit, those are things where we start to become a little bit more concerned. Those are higher risk. But the trouble with hydronephrosis is the grading system. We grade it in several different ways. So on one hand, the traditional way is to grade it 1, 2, 3, 4. 1 and 2 are really mild because 1 literally means they saw 1 drop. So I kind of think 1 should never have existed, and we should have been grading it as like 2, 3, 4, mild, moderate, severe. So a number of years ago, urologists and obstetricians and some of the pediatric groups came together, the nephrologists specifically, and came up with this new classification called UTD, right? Urinary tract dilation scale, and they used 1, 2, and 3. And what this scale is it's not nearly as widely used. It's only for hydronephrosis diagnosed prenatally. And what happens is it's trying to tell you what is the likelihood that this child has something that you need to be worried about going on. And so when you see the UTD scale, and I'm gonna hit this in another slide, grade 1 is very low concern. Grade 2 is, you should be worried. Maybe you need to do VCGs and give antibiotics. Grade 3 is obviously antibiotics, VCGs, earlier consults, things like that, because as the grade of the hydronephrosis goes up, the increasing risk of pathology goes up. Now, to further complicate things, when it comes to hydronephrosis, if a baby is dehydrated or hasn't fed recently, it might look less. If they just fed, it might look worse. The tech that does the study has a lot of impact on the study itself. And then whether the child is prone, supine, in mom's lap, hanging over mom's or dad's shoulder also affects the study, because the position of the kidney changes the pressure on the kidney and can change what the renal pelvis look like. So not all ultrasounds are created the same. So what I think of is risk stratification. What are the trigger words that should cause an alarm bell to go off in anybody's brain, including mine, that means this child we need to pay more attention to this child than the average patient with, quote, hydronephrosis. Those are cases that are severe, especially if it's bilateral. The dilated ureter, like a ureter or a tube being dilated from the bladder to the kidney, that is a big buzzword or a big trigger word. Dilated ureter is a big thing. Now, a lot of times my radiology colleagues will have like some mild dilated proximal ureter. That just means they saw a little bit of something. But when they talk about the ureter being dilated from top to bottom or tortuosity in the ureter, those are things that should perk your head up a little bit more. Anything having to do with dilated bladder, or keyhole signs, or dilated urethra, those are all buzzwords for posterior urethral valves. Patients with these words who have a history of anhydramnios or oligohydramnios are obviously at increased risk for having kidney problems. And then the more severe variants, the grade 4s, the UTD3s, those are the buzzwords right there that as long as you pay attention to those, you're going to catch most of the bad stuff in a prompt fashion. When it comes to, you're seeing a baby in the newborn nursery or even in your office in the first week of life, and, you hear any of these words, well, we encourage early ultrasounds in the first day or week of life. They're a screening test. So if I get a phone call from an outside hospital, an outside nursery, and they say, I've got this baby, there's hydronephrosis history, they said it was on both sides, we're not sure what's due, then I say, just get an ultrasound. Because an ultrasound done the first day or two of life is a great screening test. Like if the child has terrible swollen kidneys, it's going to find that. If the child has a bladder that's distended up to their diaphragm, it's going to see that. And you're going to say, ooh, I need to be much more worried about this child. It's not the end all be all. It's not the only test you should do, but an ultrasound done the first day or two of life is a great screening test to make sure there's not something more severe going on. Can I send this baby home? The reason it's not the only test you have to do is because babies are born in a state of dehydration or relative dehydration. You can take a child that has mild hydronephrosis on day of life 2 ultrasound, repeat it 3 weeks later, and all of a sudden their hydronephrosis has tripled in severity because their relative dehydration was overcome in the first 2 weeks of life and the dilation of the kidney just got worse. When in doubt, prophylactic antibiotic. I will talk a little bit more depth about this, but it's not the worst thing ever. We don't need to give everybody prophylaxis, but if you're not sure, if you're concerned, if there's any trigger words, prophylactic antibiotics is always the right thing to do from our perspective. So if you've got a patient in your office, let's say you're not worried about valves or these severe things, what's the bare minimum you should do for any human being that's born with a history of prenatal hydronephrosis? And that is at least get a kidney and bladder ultrasound. Please don't dismiss the patient as being fine because the hydronephrosis resolved or they told me it wasn't that big of a deal. There's no reason not to do an ultrasound on these patients. They're cheap, they're cost effective, and there's basically no risk. The reason that I tell you this is every single year, and sometimes more than a year, I have a family who ends up in the children's hospital here, or at my previous opportunity, my previous job, where there is a missed case of posterior urethral valves, and it's a family that's relatively smart that talked to a pediatrician or somebody in the nursery and then somebody at their group, and everyone just kind of said, oh, we'll get that later, we won't do that, or we don't need to. And you have cases of posterior urethral valves that get missed every year we see it. And so from my perspective, what I tell everybody that I talk to from a primary care perspective is, if somebody says prenatal ultrasound or prenatal kidney anything, then the answer is just get yourself an ultrasound. It covers your bases and it's the right thing to do for your patient. And you really can't rely on the accuracy of what the parents are telling you the obstetrician told them a couple months before they were born or a couple weeks before they were born. It's a very murky segment of healthcare to rely on that aspect of history. And so for me, I just can't preach enough to get ultrasounds. They're easy and they're quick. Okay, what other testing do we do? We do VCUGs. VCUGs are not the worst thing ever. We don't need to do as many VCUGs as we did in the early 2000s, but from a practical standpoint, VCUGs are okay. Kids that get VCUGs are ones who have hydronephrosis, especially with a UTI in their history, or patients with trigger words, severe hydronephrosis, dilated ureter, dilated bladder, things like that. You bring them to a urologist office, we're almost always going to get VCUGs in those children. We're not going to get VCUGs anymore in the 4-week-old boy with mild bilateral hydronephrosis or mild unilateral hydronephrosis. We're looking to do VCUGs in a more select patient population, those who have higher risk of having pathology. And so in your own practices, if you're thinking about getting a VCUG, it's okay to do it. Don't feel like you can't do them anymore. But from a practical standpoint, we're doing them in patients that we think have a higher risk, a family history of reflux, a family history of valves, things like that. You're doing them in higher risk patients instead of lower risk patients. We also do renograms. Renograms show us the function and drainage of a kidney. I would encourage, there's a tremendous amount of interpretation that goes into renograms. The nuclear medicine reports that we get are very technical, and they have to be interpreted in the clinical context of the patient. And so anybody that's ever thinking about getting renograms out of their office, I would encourage you to have a nephrologist or a urologist sort of also helping with that patient, because those studies can be, the reports frequently are excellent depictions of the study, but don't all, they need to have clinical interpretation. So the question I get a lot is these kids with mild hydronephrosis that probably plague your practice. What do you do? Do you treat them? Do you follow them? Do you refer them? So you stratify the patient's risk, number one. So you do an ultrasound on a child and they've got mild hydronephrosis. Well, if the child's growing, gaining weight, healthy, robust, not having any problems, there's no family history, they're a reasonably compliant family, you believe they would show up if their kid had 104 fevers, things like that, well, you probably don't need to do prophylaxis. You probably don't need to do much more. I'm a big believer in always getting a second data point if there is a finding, right? So if I have a child in my office who's a couple months of age or even 6 years of age, and they have mild hydronephrosis, I'll frequently say, this is probably nothing. This is probably normal. You have no other symptoms. It's an incidental finding, but let's just repeat it in 6 months or 12 months to make sure that nothing's progressed or changed, that your kidney, especially in infants, has grown and developed normally over 6 or 12 months, because then that can reassure us and the parent or the patient that their kidney health overall is good. And if you're ever not sure how to do that yourself, or you're just you don't want to have those conversations, that's what urologists and in some places nephrologists are for. That's the bulk of hydronephrosis. From a practical standpoint, hopefully that gives you a good indication of when and what to do. So let's talk about reflux, because this segues into hydronephrosis, then into UTIs. So vesicoureteral reflux. Vesico is bladder, ureter is obviously the tube between the bladder and the kidney. And vesicoureteral reflux is nothing more than the abnormal flow of urine from the bladder to the kidney, okay? Reflux happens for a number of reasons that we'll get on the next slide. Low pressure reflux, children born with grade 1 and grade 2 reflux and some grade 3 refluxes without bacterial contamination, right? Kids that are not having urinary tract infections is generally not been documented to be harmful. For the most part, what I'm saying is that just because somebody has grade 1 or 2 reflux, you don't necessarily have to do anything special to treat them or very much differently than the average patient unless they're having bacterial contamination, UTIs. That's the biggest factor that impacts things. Reflux in the presence of infection, right? So kids that have reflux of any grade is a risk factor for having upper urinary tract infections or pyelonephritis, right? So if you have cystitis in a 3-year-old girl and they have reflux, that could allow that urine that's infected to reflux up to the kidney, leading to pyelonephritis. Now, pyelonephritis carries a lot of different definitions, right? As a urologist, I generally think when families are in my office, pyelonephritis is the 103, 104, 105 fever kids that require 3 to 5 days of antibiotics for their fever curves to come down. Those are sick kids. Those are kids that you see in your office for the Herceptin shots every other day and things like that, or spend a couple days in the hospital. Then there's the febrile UTI kids with 101 fever, they have a UTI, you give them their antibiotics, they get better in a day, they're not doing that bad. And then there's the UTIs without fever, the non-febrile UTIs. But if you have reflux in any infection, you're at a much higher likelihood for the more severe infections that I talk about that are the ones where we worry the most. Because untreated upper tract infections lead to acquired renal scarring, and renal scarring is basically taking a segment of kidney that worked normally, causing it to be scarred, which means it doesn't work normally anymore, it's not functional, which ultimately leads to reflux nephropathy in children, which is a significant source of morbidity and mortality. So if you look at reflux, a lot of the, sorry, I apologize, I have to move some congenital abnormalities of renal development, right? So having ureteroceles, having hydronephrosis, a lot of them are associated with reflux. Kids with horseshoe kidneys, all these renal abnormalities can be associated with reflux, but reflux nephropathy rarely results without the history of a UTI. It can, but it's really rare unless the child has some other history in the interim. And so kids with congenital abnormalities, you have to be of the kidney, you have to be just consciously aware they're more likely to have reflux than the average population. And why do we care? Because of renal dysplasia and scarring. And so let's talk about scarring in UTIs and kidneys and reflux. So we use renal scarring as a marker for the child's reflux has impacted the kidney. So if you take all comers of refluxers, and it's not on this graph, if there was a 0 here for UTI, you would see that children born with reflux, if you look for scars with a special renogram that looks for scars, about 5 or 6% have a scar just because they had reflux. That mechanism that allowed the ureter and the renal mesenchyme to interact didn't form the entire kidney normally. So just having reflux carries a baseline level of scarring of about 5% or so. If you have one urinary tract infection, that risk is about 6%, barely up. If you have a second urinary tract infection with reflux, 10%. The third, 16 to 18%. The fourth, 35 to 40%. The fifth, 60%. So you can see this is almost a reverse exponential curve, right? It's climbing up the volcano. So if you think of the world of reflux diagnosis, most of the time reflux gets diagnosed after a UTI, right? So you have UTI number 1 right here. So, okay, we do your ultrasound, we diagnose your reflux, we get your VCG, and we say, all right, we're gonna put you on antibiotics and we're gonna wait and see if you outgrow it. Once you have infection number 2, that puts you in this risk category right here. This is when the urologists of the world are supposed to start saying, you've had 2 significant infections. We don't want you to have a third, because once you have the third, your risk of scarring starts to go up to 1 in 5 or higher. And so the reason that a lot of times urologists like to do the VCGs after infection, number one, and think about treatment here, is because we want to help patients avoid being on this steep part of the curve, right? And this steep part of the curve starts basically with a third UTI. Now, if you look at kids with congenital dysplasia in grades 4 and 5 reflux, so if you have a child and you get that VCG report back and they just state, this child has grade 5 reflux. If you do a study looking for dysplasia, which is another way to say scarring, different way, they're different things, but they're similar from your understanding purposes, there's a 50+% chance that those kids have some dysplasia or abnormality, which means decreased function in those kidneys. So those are higher risk individuals as well. So we care a lot more about grade 4 and 5 reflux, especially in the presence of any UTIs, because you're fighting this curve and you're fighting the fact that they're already starting at a disadvantage compared to everybody else. In the world of reflux, this is the ureter right here coming down into the bladder. If the ureter doesn't make a long enough tunnel or comes in with the wrong angle, as the bladder fills up, urine can go back upstream. If a ureter comes in and makes a nice long tunnel, then it's very unlikely for reflux to be able to go back upstream. The reflux we're talking today is called primary reflux. That is an abnormality of how this tube inserts into the bladder. There is secondary reflux, kids that have voiding dysfunction, strictures, valves, neurogenic bladder, that because of increased bladder pressures cause reflux as well. We're going to stay focused mostly on primary reflux. So the incidence of reflux is much more common in boys, especially when they're infants, and also in girls when they're school-aged. Why does that happen? Because girls, when they're school-aged, are much more likely to have UTIs, and they're much more likely to get their reflux diagnosed. UTI history, if you take all children and you have no history of a UTI, the likelihood of finding reflux in a population is less than 1%. If you take kids who have had any sort of UTI, that rate is between 20 to 50%, depending on the study you read. So having a UTI is one of the most important prognostic factors to point to somebody that definitively has reflux. We do find, and this data is well stratified, that reflux is less common in African Americans and individuals of Mediterranean descent compared to Caucasians, and it decreases with age, right? So you find less reflux the older kids get, and that's mostly thought to be due to spontaneous resolution. As kids get longer, that little tunnel mechanism stretches out, and sometimes kids can outgrow their own reflux. And on a note of outgrowing reflux, you can Google reflux resolution calculator. I believe it comes out of Boston Children's. You can type some very basic criteria into this calculator, and a data pool of thousands of kids can actually tell you, given your patient scenario, what the likelihood of their reflux to resolve in a 2, 3, 4, and 5 year time frame. It's just, and I don't know the specific address, but I do it every now and then for families. And I Google reflux resolution calculator. It's out of Boston Children's. It's a great tool to explain to families how long it'll take and what their rate of resolution is. So one of the PCP questions we get a lot is siblings. If Janie has reflux and we just had Johnny, our new baby, what's the likelihood of them having reflux? It's about a third, it's about 30%. But sibling screening is no longer recommended as routine. We did it for a decade or more. We gave all the siblings VCGs and we found all sorts of reflux that we didn't need to find, because reflux found incidentally because of mild hydronephrosis or sibling screening is less likely to be pathologic, more likely to be lower grade, and higher likely to resolve on its own without intervention. So we have scaled back from trying to diagnose incidental reflux, such as in siblings. Now, that being said, every now and then I've got a family sitting in my office and they're like, they've been through the ringer. You know, they've got a little renal insufficiency. They're seeing the nephrologist, they've had surgery, and they can't bear the thought of their child not, you know, having that, the newborn not having screening. And the way that I do it for them is I say, you know what, if I'm compelled to do it, I'll just do an ultrasound. Because if your child's kidneys are normal size and your child's kidneys grow normal length over time, then your child probably doesn't have, and your child's growing and gaining weight and developing appropriately, they don't inherently have renal dysfunction, right? So then it's not necessarily needed to screen it. So those families that really feel like they need it, I try to explain why an ultrasound to look for kidney size, growth, and health is probably all the screening that their child needs. How do we find reflux? Prenatal ultrasonography, dilated ureters, severe bilateral, UTIs, kids with unexplained febrile illnesses, kids who have other bladder disorders like valves, and we diagnose it with VCGs. You can do nuclear medicine studies. They're not as good, and the data tells us that if you do nuclear medicine voiding cystourethograms, it's best to do them as follow-up studies, not as primary studies, because they don't give us the same anatomy. Nowadays, with the ALARA principles, the radiation reducing principles for kids that we use all the time, VCGs should no longer be 30 image studies. They should be much shorter studies, much lower penetration studies with a much lower radiation exposure for kids. Reflux grades on a scale of 1 to 5. If you were born in Europe and you had grade 1 or 2 reflux, they generally dismiss that as a clinical problem unless you have UTIs. This is mild reflux. Grade 3 is moderate, and grade 4 is more severe, and grade 5 is the most severe. 4 and 5 are most severe because we call it dilating reflux. The diameter of the kidney tube and up in the kidney starts to get dilated. And when we see it get dilated, that implies, doesn't mean for sure, but it implies increased pressure or tension. Those are things that you could theorize are potentially damaging to nephrons and renal papillae up in the kidney. So when do you do the VCG? It's a little controversial. What I mean, when do you do the VCG? I'm talking about the child that's had a recent infection and you're trying to figure out when do you get the VCG? Should you do it right now? Should you do it on antibiotics? We get this question a lot. The most important thing is you don't want to put an actively infected system that might reflux under pressure, right? So we generally tell people don't do it during an acute active infection. If you're going to do a VCG while a patient's on antibiotic therapy, the fever and the symptoms need to have resolved, right? And in those cases, a lot of times it's reasonable to have had a negative urine culture before you do the VCG, or say, you know what, we're going to do 10 days of antibiotics. As long as the child's doing well, we'll do the VCG on day 9 or 10 when the infection's basically treated and we're just kind of mopping up the end. There's also another thing that I bring up a lot for pediatricians is, let's say there's a family that you're going to send home and there's difficulty getting the VCG the right time frame. There's no reason that you can't, when you assume that this child very well might have reflux, you can give them their treatment antibiotics and then follow that up with a prophylactic prescription and have them get their VCG in 2 or 3 weeks. There's no hurry, because let's say they get their VCG at the end of their antibiotics and we diagnose them with bilateral grade 3 reflux. And they come see me that very day. I'm going to say, well, here's your antibiotic, and this is how we're going to watch it, and this is what we're going to do. And their treatment's going to be the prophylaxis. So what I tell people all the time is, if you can't fit it into the perfect box, assume the patient has it, do a little prophylaxis, and then get the VCG when you can, since that's basically going to be the treatment for the patient anyway, up front in most cases. So then when it comes to managing reflux, what is it that the urologist and the pediatrician should be thinking about? Number one, we want to prevent pyelonephritis. We want to prevent kidney infections. We want to treat kidney infections early and promptly and quickly. We want to prevent recurrent UTIs and the development of new renal scarring. We want to monitor renal health as well. That's something that urologists have not always been the best at doing. You know, and I tell parents all the time, you know, sometimes we discharge them from our care and I look at them and I say the most important thing for your child is when they're teenagers and 20-year-olds, just make sure they're getting their blood pressures checked, things like that. So kidney health, like these kids have a slightly higher rate of having kidney problems later in life, even after they get discharged and we fix everything and they're cured. There's both medical and surgical management. The medical treatment's pretty simple. The medical treatment is time, number one, but then it's also continuous antibiotic prophylaxis. You'll see that abbreviated as CAP, C-A-P in these slides. The common antibiotics we use are Bactrim, right, sulfamethasol, nitrofurantoin, macrodantin. Now, macrodantin liquid, everybody, is terribly difficult to obtain, requires prior authorization, usually takes like weeks to get shipped into the pharmacy. It's a nightmare. You can take macrodantin capsules and open them. They come in 25s. They come in nitrofurantoin capsules, apologize. They come in 25s, 50s, and 100s. You can sprinkle them in liquid or in applesauce or pudding, fill in the blank. So nitrofurantoin is a valuable option, and you can use the capsules for a lot of kids, not everybody, but a lot. Cephalexin, and then amoxicillin. Amoxicillin is the world's worst prophylactic antibiotic. We use it all the time because it's the only safe thing to give to the newborns that we deem safe in the first, 30 to 60 days of life. However, you'll notice as soon as they come to our office and they're outside of that window, we switch it over to something that has much more broad coverage. It's a little better prophylaxis. So let's talk about what prophylaxis does. We used to give this to everybody, and we were wrong. Pediatrologists did this way too much. That being said, it's still indicated for certain patients. And what does it do? If you take children in the river trial that we did not long ago, and these are kids between the age of 2 months and 2 years, right? So it's a broader age range of kids that I apologize. It's a different study I was thinking about. But you take kids with reflux and you randomize controlled trials, some of them to prophylaxis and some of them to not prophylaxis. And you look at what it achieves one thing, one very specific thing. It reduces the risk of that child's breakthrough UTI as a population by 50%. So 50% less UTIs are had by that population. Now, the criticism of the study is that, well, the kidney outcomes, the new rates of renal scarring didn't change and things like that. And that's completely right. Prophylactic antibiotics did not protect kidneys from new renal scarring. Didn't. There's no evidence that we had from that trial that showed that. However, what it does is the number one indication for the surgeon, me, who likes to do what I do to fix reflux is really simple. You have reflux, you get the breakthrough UTI. I'm worried about the steep part of that curve. I'm going to start talking about surgically fixing this instead of using time as an option. So the prophylactic antibiotic, especially in the higher risk kids, especially in the younger kids too, really reduces the risk of me having to say, you need surgery, which I might like to do, but we recognize is not the right thing for every single patient just because they have reflux. So when do you start the prophylaxis? Like if you're looking for a guideline, this is a super busy slide. It's the high risk patients and some moderate risk patients. You get a VCG report that says grade 4 or 5 reflux, in some cases grade 3, sure, fine, start it, it doesn't hurt. A vulnerable patient, right? Developmental issues, infants, 2-month-olds, 3-month-olds, kids who have a high risk for renal deterioration, right? You're getting an ultrasound report that says this child's kidneys are atrophic and are there scars. You're more worried about that patient than anybody else. It is the conservative option, right? So it's the most conservative thing we can do while we're still doing something. Kids that are high risk, right, are kids that are in foster care, kids that have compliance issues, kids that don't have running water in their house. We've all seen a lot of these kids in our practices. And then I think the more severe the UTI, right? So when I get a phone call about the 3-month-old that just spent 10 days in the hospital versus the 2-year-old that had 101-degree fever, I'm going to be way more likely to aggressively manage the 3-month-old than the 2-year-old who's in the midst of toilet training and stuff like that. And then we're going to talk about bowel and bladder dysfunction in just a second. So when do we stop the prophylaxis? That's a very common question. When do we stop it? Number one, when the reflux resolves. That's the old way to do it. We used to have these patients come see us for a VCG every year, and we'll stop the antibiotics once you finally outgrow it. Well, that is still a way to do it. We don't always do that. Sometimes we do it now when the reflux is just improving and the patient's low risk. Sometimes we do it when the patient has low-grade reflux, they're a low-risk patient, and they've been infection-free for a while. And in older kids, when we find reflux, when their bowel and bladder habits are optimized, they're not having infections, they're not having incontinence, they're not having issues with bladder emptying, we'll do it in them, we'll stop it in them. So it's okay to stop it too. Usually when we start it, we do it for a bit of a prolonged period of time though, right? We don't do it for a month, we do it for 6 months or a year, things like that. We commit to it for the developmental purposes of the child to get bigger, grow up, get over their bowel and bladder function, get out of that high risk period, things like that. Now, bowel and bladder dysfunction, those are kids that don't empty their bladder normally. Those are kids that are holders. Those are kids that have incontinence. Those are kids that have recurrent non-febrile UTIs. It's the biggest confounder we have. Kids that are having bowel and bladder dysfunction have a significant increased risk of recurrent UTIs. The rates of their reflux resolving if they don't have good bowel and bladder habits dramatically reduces. So the likelihood it disappears over time, reflux-wise, goes down dramatically if they have bowel and bladder dysfunction. And if I do surgery on a patient who has active bowel and bladder dysfunction, the success rate of an operation that boasts 96 to 97% success drops down to about 70%. So kids with bowel and bladder dysfunction are also at the highest risk of having recurrent UTIs. They're at over 50% rate of having a recurrent UTI, no matter what their degree of reflux. And that's higher than a patient who just has grade 5 reflux alone without bowel and bladder dysfunction. So bowel and bladder dysfunction were recognized as one of the biggest confounders we have in the fight of reflux. And so those are fairly higher risk patients. These are the 3 and the 4-year-olds that pee once a day that have incontinence, and we find grade 4 reflux because they've had 6 non-febrile UTIs. These are kids who you're a little more worried about than others. So how do we do follow-up? What do we do for follow-up? So the truth about reflux is that I care more about how the kidneys and the child are growing than I care about the resolution of reflux. So if I have a patient with grade 3 reflux and we manage them for a year and the child's kidneys grow and they don't have infections, and let's say they were on prophylaxis and we've stopped that, and then their child is 3 or 4 and we think, are we going to get that VCUG again? It all depends. If I think that patient's moderate or high risk, I will, because I think that's valuable to know and to not go unchecked. If they're lower risk or on the lower side of moderate, sometimes I just say, listen, the most important thing is for us to watch your child's kidney health and your child's bowel and bladder habits. So we don't always do repeat VCGs. I myself personally say, I don't like the annual VCG. Parents hate that. They dread that. I like VCGs at developmental milestones. I get a VCG if I'm getting repeat VCGs, you know, between 18 and 24 months of age, typically right before toilet training. So kids are less likely to remember it, less likely to be as traumatized by it. And then if I'm going to do a VCG on a child at age 3, 4, 5, then I don't do it at age 3, 4, and 5. I kind of say, all right, around age 4, let's just do one. And having 2 data points or 3 data points is plenty. You don't need 5 data points over 5 years to show you whether the reflux is getting better or worse. So from a practical standpoint, I think that we should be doing a good job for our patients and spacing those out more to minimize the radiation and the trauma that is associated with it. Medical monitoring. So what should we be doing for these patients in your practice? What should you and I both be doing? There's no indication for routine and regular surveillance of the UTI. There's no need to send off urine cultures randomly just because somebody has a history of reflux, unless they have symptoms. Especially in teenagers and adults, checking their blood pressure. History of reflux as a teenager and adult, you should have your blood pressure checked for hypertension. Renal scarring can lead to hypertension. In teenagers and adulthood, right, especially UAs for proteinuria, I know that the AAP recommends against routine screening in UAs in all patients, but with a history of reflux, especially higher risk, it's a reasonable thing to do at an annual physical. Obviously, height and weight. Why is that? Because kids with renal insufficiency don't grow as well. They fall off the growth curve and all the things you already probably know. Blood work. There's no strong recommendations for routine blood work. I believe in a baseline BMP. It's listed as an option in the guidelines, especially in kids with bilateral moderate to severe reflux. And then if I'm going to do it in somebody's high risk, I'll repeat that again, either just before or just after puberty as well, just to make sure. Every now and then, once every year or two, I'll see some patient that didn't slip through the cracks, but was thought to be low grade, and they come back and they're teenagers and all of a sudden their creatinine's 3 times what it should be, and they're having a whole different set of conversations. And so I don't do much blood work, but I definitely do it in select patients, and in high risk patients, I usually recommend for it to be teenagers. But if all you did was blood pressure monitoring, right, and watch the height and weight, you're probably doing enough. If you add in proteinuria, especially in teenagers and young adults, that's great. Surgical management of reflux, recurrent infections, breakthrough infections with resistant organisms, right? Whenever you need gorillacillin to take care of your infection, we have a tendency to want to fix that reflux more. Medical non-compliance, persistence of reflux in high-risk patients, right? Grade 5 reflux, bowel and bladder dysfunction with UTIs, kids with renal scarring. Now, let me talk about non-compliance. I had a call today from a super nice family who lives 6.5 hours away that doesn't have a pediatric urologist anywhere near them, right? They opted for surgical management because they don't like living their life 6 hours away from a specialist that can help them. They want their child to be fixed. And it's been a big burden on them to go back and forth and things like that, right? So it's not just non-compliance, it's also situational. We see that in our military families. Some of our military families that are deploying or going to areas where there aren't particular subspecialists sometimes lead to surgical management. But we do a lot less reflux surgery than we ever used to. The data actually shows us that. So in the last few minutes, let's hit UTIs, okay? I'll do this as quick as I can so that we can ask questions. Number one, UTI, it's pathologic, right? We want 2 things to diagnose a UTI, urinalysis and the presence of a single uropathogenic organism on the culture. Why is it important, right? Urinalysis is a picture of what's happening in that child's bladder at that moment. If you have no inflammation in that child's bladder, you probably don't have an active infection going on. So, but we want to confirm both the urinalysis and we want a culture. The method of collection in a non-toilet trained child, a catheterized specimen is the best. I understand many of you don't do those in your offices, and that's okay. If you use the bag specimen, please, please, please get it with urinalysis. Because if you call me with a bag specimen result and your urinalysis was basically normal and then the culture grew some, funky booty bug, then I'm much less likely to think that's a real UTI. And if bag specimen's positive and you call and say, what should we do? We're not sure if this is a UTI or not. We're going to say a cath sample. The last thing that I tell you is, and I understand that this is a sticky situation, but if you're going to do bags, get urinalyses and cultures. Don't just get cultures. The urinalysis helps us a lot. If you've got a toilet trained child though, I tell the parents to get your hands wet. I know that sounds gross. That might be a little weird, Number one, please, 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 we just want a sample from the midstream. I want mom or dad or whoever needs to be in there wiping and cleaning, have the child start peeing, catch some midstream pee, and then pull your hand out and let the rest of it go in the hat of the toilet. Don't scoop it out of a hat. Don't catch the whole sample. There's lots of cruddies and yuckies at the beginning of peeing and at the end of peeing when it comes to urethras and meatuses and little boys' penises and vaginal areas and everything else. So a well-checked sample is really important, because I think a lot of kids sometimes we see for UTIs are not always having the best samples collected. And again, I really recommend a urinalysis up front. You will see a host of patients that have asymptomatic bacteria. We get that a lot, especially in young school-age girls. You can have a prevalence of up to 1% of them having asymptomatic bacteria. There's no clinical symptoms. You check a urinalysis, it shows some possible leukocyte esterase. You send a culture, they grow some bacteria, right? So this happens a lot. And what we tell pediatricians and what we do ourselves is use our clinical acumen. If the history suggests of a UTI, treat it. What's the patient risk if you leave it untreated, right? If they have grade 4 reflux, well, you're probably going to treat that. If it grows bacteria like Pseudomonas, you're probably going to treat that because that's a uropathogen that's significant. Or, you know, does the culture just grow some bacteria, or does your UA show 500, greater than 182 white cells, things like that? So you do see a lot of asymptomatic bacteria. You don't have to treat it like a UTI unless your clinical acumen tells you that you should. So this is where the controversy exists for you all as a group, pediatricians, because your clinical guidelines to the American Academy of Pediatrics are different than the guidelines that I preach and I use. The truth is somewhere in between, or a tailored approach is likely the best way to go, because not all UTIs are created equal. And so what I encourage people to do is not to just be a pure guideline follower, but to be thoughtful about the guidelines. So the American Academy of Pediatrics UTI recommendations, what you all in general are supposed to follow, only occur in kids between 2 months and 2 years of age. It is a narrow age spectrum. The reason it doesn't go over 2 years of age is to eliminate the bowel and bladder dysfunction population. And the reason it doesn't go below 2 months is because obviously infants have compromised immune systems. They get sicker, it's a different category. So in the world of your recommendations, it says if you have a febrile urinary tract infection, you give the child antibiotics and you get an ultrasound. If the ultrasound is normal, remember your rate of reflux is still 30-40%. It says you don't have to do a VCUG unless there's a recurrent or a second infection, and then you do a VCUG. But if you have a febrile UTI and the ultrasound is abnormal, then it says go ahead and do your VCUG. So this is your algorithm in basically, you know, toddler age, you know, late infancy or infancy and toddler age kids, just not the super early infants and kids after toilet training. Now, the truth is though, is remember that curve with that steep line. If you wait to diagnose your reflux until here in the more severe cases, that means that their next infection puts them up at that 3 infection mark, which is the 20% renal scarring mark. So urologists don't like this part. In the higher risk patients, not in all comers, the 23-month-old who's starting to toilet train that has 101 fever is different than the 3-month-old with 104 fever. So I generally agree that we should minimize VCGs, but if a patient is hospitalized for their infection, if they were the kid that had 105 fever, 104 fever, 103 fever that lasted for 3 to 5 days, I'm much more worried about that kidney. If they have significant risk factors like non-compliance, right, or the family history strongly positive for renal failure or reflux, the parents just beg us to. And a lot of times I think the infants that have less ability to speak up for themselves, especially more under 6 months, but I write that under a year of age. So it's okay to not follow your guidelines blindly, especially if you feel like that patient is higher risk than the average patient sitting in front of you. From a practical standpoint, that's the end of reflux, hydronephrosis, and UTIs, what I think you should all, at least at a basic level, know. Hopefully this gave you some insight into the data a little bit. My email address is up there. I'm more than happy to take any questions you guys have. And if anybody ever has questions, needs to talk, wants to talk, I'm more than happy to hear from you all at any point in time. I'll open the floor up to questions now. I'm going to stop sharing my screen so that Dr. Gale comes back up.
Well, thank you, Dr. Stead, for this enlightening talk and some really important topics in pediatric urology. I mean, most pediatricians will see some, if not all of these during their lifetime. So thank you. So there's a question here. First question is, what is the best timing to perform renal ultrasound in a child with prenatal diagnosis of hydronephrosis?
So that's a very good question. And the ideal time to perform that particular imaging study is around 4 weeks of age in most children, in most cases. Anywhere after 2 weeks is fine. The only time you really need to do it in the first day or two of life is if you're worried they're high risk. The mom can't tell you the right history, or the dad can tell you the right history, or they're saying words that concern you, right? That's when you get it in the hospital before they leave, just to make sure that it's not the valve child that just is getting underreported to you, the pediatrician or the family medicine provider practitioner. The ideal time is after a couple weeks. After 2 weeks, that state of dehydration is done, and it's much more representative of the degree of hydronephrosis in the child's kidney at that point. And the vast majority, even the mild, even the more severe, it's fine if we find out at that stage. So around 4 weeks, a little sooner is fine. If you do an ultrasound on day of life 2, and let's say it's normal, unfortunately, you're still obliged, or you still should repeat it somewhat down the line, maybe a little further out than 4 weeks, just to make sure that the child's dehydrated state didn't play a factor in why the ultrasound was normal. And so hopefully that answers your question.
In regards to prenatal patients, what is the current studies or surgical approach to patients who are diagnosed in utero with a significant hydronephrosis? Where is the state of the art with that now?
So if you take the children with, so let's talk about 2 groups. Let's talk about kids with bladder outlet obstruction, posterior urethral valves, things like that. Most of the prenatal surgeries and things that can be done are only done in a select group of patients that have sort of favorable prognoses. So it's a very small subset of those patients that will get prenatal surgery. So in the bladder outlet obstruction patients, those are ones that we tend to intervene on like in the first couple of days of life. They're born at the tertiary care centers or transferred in, things like that. If you go to just the hydronephrosis patients, so let's say you have a child who's born with severe hydronephrosis in one kidney, but the other kidney's fine. And ultimately, we're going to figure out that they have a UPJ obstruction. The data tells us that you can fix that anywhere between 6 weeks and 1 year of age, and most, not all, but most renal outcomes are the same. So it's usually surgeon dependent, it's family dependent, situationally dependent. I tend in those kids to get pretty close ultrasounds, because sometimes in the severe cases, you'll see on one ultrasound the meat of the kidney, the parenchyma looks a certain thickness. And then on the next ultrasound, you're like, oh, it's a little thinner. It's a little thinner. Those are ones that I'll say, ooh, I'm going to fix this at 3 months of age instead of waiting until 6 or 10 months of age. The reason we have that leeway is some people just aren't comfortable fixing this in younger kids. Most of us will fix it in kids, between 3 to 6 months in a heartbeat. And so that's really the significant intervention that we do. The only scenario that changes that is if they have a solitary functional kidney. So if a child is born with only one kidney, it's got a UPJ obstruction, they're no different than a child with like a posterior valve. They need some form of urgent intervention to help that kidney drain because it's their only kidney. Or if a child has a multicystic dysplastic kidney on one side and a UPJ on the other, the multicystic kidney is basically a kidney that doesn't work at all, and you're more worried about that hydronephrotic solitary kidney. So that being said, kidneys are very distensible. They're very easy. They can accommodate a lot of sort of pressure and volume without necessarily being impacted and losing function. So in many cases, there's actually a little bit more time than you would think, but I don't sleep on the more severe ones very, very much.
Thank you. Well, I see the audience are still very quiet with questions. Oh, I don't see a second question. So let me see what this person. This participant is asking, any suggestions on getting accurate abnormal prenatal ultrasounds results to the peds? These are often, oh, by the way, from parents right after delivery, and records can't be found. Records from high-risk OB often not on the mom's chart, or never got records to hospital by delivery. Have you seen a good system in any of your previous communities for relaying this to the PAP from relating to the PCP from the OB?
So to just be blunt, no. This is one of the biggest divides and one of the biggest discrepancies in healthcare is that the mom is technically the patient of the obstetrician and the baby is the patient as soon as they're born, right? So there's a discrepancy there in information. So there's no great way that I've found. I do think the high-risk groups like here in Jacksonville, like Rock, currently has a coordinator whose job it is to help relay a lot of that information. But in the same capacity, these are also patients that, so, they sort of deliver and disappear, right? So it's not, those patients don't always have the same quick follow-up with their obstetricians, but there isn't a great system. And so I get it, these are the kids that say, oh, by the way, my kid has this problem, and you go, oh, great. That's why one of my very first slides is just get an ultrasound. If you get an oh, by the way, no problem. We just got to order you an ultrasound. Just order the child an ultrasound is the way that I look at those oh, by the ways, and then see what the results are. I think it's part of most screening questions, or most, it's listed as most screening questionnaires for babies is any problems with prenatal ultrasonography. I mean, half our parents aren't going to answer that question accurately. There's only so much we can do, from that standpoint. But if there's any doubt, or if there's any mention of anything from the parents, then I just get an ultrasound. And the important thing is probably more to ask the question in a way that a patient understands. You guys do this for a living. You understand exactly what I'm talking about. Saying, did your child have hydronephrosis doesn't make sense, but asking questions like, did you have to come back for additional ultrasounds? Was your obstetrician worried about anything on the ultrasounds? Did he say anything was not normal? Just sort of more peppering them with a question or two in that regard is sort of just a way to dive a little bit deeper. It's sort of front and center on our urology questionnaires when people check in, but there isn't a great system, I'm sorry to say. But in the same capacity, it's why no matter what the parent says, just get an ultrasound. Covers your basis for the patient and for yourselves.
Great, thank you. All right, one last question from me. I don't see any other questions from the audience. You may have covered this in your talk, and I apologize if you did cover it. In terms of surgery for the patient with reflux, at what point would you say surgery is definitely needed in a patient with reflux?
So if there's evidence of impact on the kidneys, if reflux is having issues with recurrent infections, especially febrile infections where they're going to the kidneys, if reflux is causing the kidney to not grow as well, if the child has dilating reflux that's causing hydronephrosis in the kidney, the more severe variants of reflux that have higher likelihoods of kidney dysfunction associated with it. So the most absolute indications for fixing reflux is to protect kidneys, primarily to protect kidneys from additional infections, or some people believe, there's mixed data on this, to prevent kidneys from seeing increased pressure from reflux. But it's primarily, if you look in the data and the literature, designed to keep patients away from having kidney damage and dysfunction. So recurrent infections, severe reflux, or other signs of kidney issues is our number one indication these days.
Great. Well, again, thank you so much, Dr. Stead, for this enlightening talk, and really appreciate your presence this evening.
Thank you all. It was my pleasure.
Thank you very much again. So I'll hand it over now to Faith.
All right, thank you so much. Thank you, Dr. Steck. That was very practical and informative, and I know our audience is appreciative of all your knowledge. Thank you, everyone, for attending tonight. That concludes our presentation. I have two quick announcements for you. We have recorded tonight's presentation, and we'll be sending out this recording along with these CME instructions sometime next week. So if you missed something or want to go back and take more notes, know that that recording is coming. And my second note on this slide, along with the chat, I have put the link to get credit along with the code for this specific presentation. For any of you joining us tonight that are licensed outside of the state of Florida, please note that the email has changed for who you need to reach out to request getting an official transcript of tonight's presentation. So please just make note of that. I will keep this slide up here for a few moments, You're welcome to copy it from the chat. And like I said, I will be sending out instructions next week. Thank you all again for coming. Thank you, Dr. Steck, and I hope you have a great evening. Thank you.